femur and about 90 at the knee, okay? So this angle is about 45 degrees, okay? And about 90 degrees here, okay? So this is active drawer. So if you hear the word active, who's doing, can you slide a little bit towards me?
The patient.
Patient.
Yeah.
So the patient is the one doing the work.
Are we saying 90 or 95?
This is 90.
Okay, sorry.
It's 90 here and 45 here,
Okay,
okay?
okay, thank you.
Okay. So, right now I'm just going to observe the contour here, okay? She's got quite a prominent tibial tuberosity there.
Mm-hmm.
Do you have Osgood's?
I don't think so.
Is that tender?
No.
No? Okay. Fine. So, I'm just observing this contour. Now, we've talked about this before in the shoulder. We talked about it in context of a sulcus sign, okay? So, if I see her tibial plateau falls back, then there's going to be a divot here of the tissue, all right? That tells me, if, and depending on how significant it is, that tells me that she's had a PCL rupture.
Doesn't sound good.
Okay, so it would look like this. She'd bend, okay, and as she bend, remember, the knee doesn't just hinge, okay. That'd be a huge gap if it did. So what does it have to do? Those condyles have to slide on the plateau, okay. So I get her up to that 90-degree angle, and if she has no PCL, grade 3 or greater, it does this. The whole tibial plateau falls back, and the soft tissue divots in, okay? So I'm just looking for that initially observationally, okay? So that's a ligamentous thing. So if I have her contract her quads just slightly, as if you're trying to kick me off the table, okay? So what do you think would happen to this contour when she does that?
It's worse.
What was the question?
Should pull the tibia back out too.
Okay, so the contour, the sulcus sign would increase or decrease?
Oh, actually, increase. Because you have a quad attaching to the
Would the sulcus get bigger or smaller? Smaller, okay? Just watch. Falls back. Quads come up and over, comes over the patella. Patella's there as a mechanical, gives knee extension a mechanical advantage, okay? It's just basic physics on that one. Goes up and over, attaches tibial tuberosity. So if we did this, boom, it falls back, and she contracts her quads, it's going to shift forward, okay? And it's going to come back out fairly level, all right? But what you're going to see is a lot of gross motion, okay? We had a guy a few years ago that had, and he never got him repaired. He had a PCL and an ACL tear, complete, okay? He just decided, I don't want to have the surgery, okay? Which is fine. You're just going to have to rely a lot more on the other restraints, i.e. muscles, things like that, to give him some stability. But it's vulnerable. I'm going to tell you, you need those guys, but he just decided not to do it. And when he contracted his, we could all see the sulcus. It was huge. I mean, it was like, bam, it's like back here, okay? And he'd contract his quads. Because he had no ACL either, it went way forward. So the position of the sulcus reversed. And it was, I mean, his tibial plateau, I'm not kidding you, it probably moved a good 6 inches, it looked like. It was crazy, okay? No pain. He had no pain with that at all.
Gross.
And we had fun with it.
That's gross.
Contract, relax, contract, relax. And he was like, bam, 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 bam. Huh? Yeah? She hadn't had hers repaired either? Is it PCL or ACL or both? Both? Okay. Yeah, let's have some fun with it.
Someone
All right?
record that.
Yeah, for real. Somebody get that on video.
Okay? So, but the active drawer means they're doing the drawer actively through the quad contraction. Okay? So mostly we just look for PCL falling back, okay? So if it was just PCL and she contracted, it's going to kind of basically come level, all right? If there's an ACL included, it's going to come way far forward and back because there's no drawer coming in or out, okay? So, yeah.
Even after surgery, that I had an ACL surgery, I still sometimes go forward.
It still has a little bit of play in it. Yeah.
Still laxing too.
Yeah.
And also got him also I'm not gonna one got a free because the first time they used the medial hamstring,
Right.
it didn't work.
Yeah.
And then I got the ligament, the body ligament in the body. It worked, but then I got an infection. So that's also one reason why it's still going through.
So you still have some, even though they tried to repair it, there's still some laxity in it. Yeah, exactly. So, all right. So passive drawer means I'm going to do the work, guys. Okay. This is a great way also to palpate for joint line tenderness. Okay. So her joint line's right in there. We kind of established that when we did varus and valgus. So my thumbs are right on top of her tibial plateau. Okay. So for anterior drawer, I'm going to pull it forward. What limits that motion is her ACL, or her anterior cruciate ligament, excuse me. Anterior cruciate. Cruciate means what?
Cross.
It's a cross, okay? So we pull forward. By me putting my thumbs here, gapping the joint line, okay, I can feel the tibia relative to the femoral condyles and the movement between them, okay? So I don't want you just to grab a hold of the tibia and move and just sight line it. I want you to actually feel for it too, okay? So we're gonna pull in here, okay? Now, if she's had a grade 1 or grade 2, if it's fairly acute, that's probably really painful. They're not gonna like it, okay? She may even have some swelling in there, okay? You may have to defer your exam till later to see the extent of the damage until some of the swelling and inflammation goes down, okay? And that's the same with any joint provocations, okay? If it's too acute, not much you can do at that time, all right? So to look at the PCL, I just change the angle. So right now I'm pulling here for ACL, just pulling straight through it. PCL, I'm going to break my thenar is up here, okay? And I'm going to shear back. So basically I'm trying to take her plateau and shear it underneath the back side of the femoral condyles, okay? All right. So that's the basics of a drawer, okay? So just think of a drawer at the house. Opening a drawer, closing a drawer. It's a shear or translational movement, okay? The thing with it in being in this position, think of where it is relative to the condyles, okay? If the condyles, if you look at these two condyles, they're like big horns of a ram or something, okay? So we're basically on the posterior surface of those, sliding that plateau back and forth into there, okay? So let's do passive, and let's do your active, both anterior and posterior, okay? Do it